It's time for another Morning Pointe Foundation Caregiver Café, part of the work of the Morning Pointe Foundation, providing nursing scholarships and caregiver support programs across the Southeast. Thank you, donors, for supporting our 4 annual Seniors Got Talent shows and our 2 annual golf events. And now, bi-monthly virtual caregiver cafes featuring senior living experts. This episode features 2 special guests, Curt Bicknell, a pharmacist and the president of Guardian Pharmacy Mid-South. He has more than 20 years' experience in healthcare and is a graduate of UT Memphis. He is joined by Gayle Lee, an RN, account manager and nurse educator, also with Guardian Pharmacy Mid-South. She is a board-certified gerontological nurse and holds a Bachelor of Science in Nursing from the University of Tennessee and a master's in professional studies in aging services. Please welcome our featured speakers as they lead us in an informative discussion, senior medications and fall risks. Welcome.
Well, good evening. Thank you for joining us on the Caregiver Cafe this evening. Welcome. If that slide just clicked to me, just welcome again. Thank you for joining us on the Caregiver Cafe. So happy to be with you tonight. My name is Curt Bicknell, and I'm president of Guardian Pharmacy. I'm a pharmacist, and I want to thank Morning Pointe Senior Living for giving us the opportunity to talk to you about a subject that is near and dear to our heart. We'll be talking about medication and fall risk tonight. But before we get started, I want to go ahead and have Gayle Lee introduce herself. And Gayle, I'll pass the mic to you for just a minute before we get started.
All right. Hello, everyone. Thank you all for joining us this evening. I'm Gayle Lee. I'm a registered nurse. I'm the nurse account manager and educator for Guardian Pharmacy Mid-South, and I'm very excited to be here with you as we discuss psychoactive medication and fall risks.
Thanks, Gayle. And before we get started, I do want to let everybody know that we're going to have a question and answer session at the very end of the presentation. So in your Zoom meeting, you should be able to see a Q&A box. So we'll hold the questions and answers for the very end. But as we go along, if you can think of something that you would like to have addressed at the end of the presentation, go ahead and type your question in that Q&A box down on the toolbar at the very bottom. And then I'll open that at the very end, and we'll be glad to start some discussion on the Q&A session. So again, welcome. We're happy to be here. And I'm going to go ahead and share my screen, and we'll get started this evening. Oh, excuse me, folks. Beg your pardon. Give me just a moment. I'm so sorry, folks. We're having a little bit of technical difficulty. Give me just a moment here. Okay, folks, hopefully you can see that a little bit better. Gayle, can you verify that we're seeing the correct screen? Okay, and I apologize about the technical difficulty. So let's go ahead and get started this evening, and we'll talk about psychoactive medications and their impact on fall risk. So some of the objectives that we want to share this evening, several things. First of all, we're going to identify common risk factors for falls. We'll also distinguish preventable falls from non-preventable falls. We're going to pinpoint contributing factors, including age-related changes in medication properties. And then we're going to review psychotropic medications commonly linked to falls. And then finally, and most certainly not least, provide strategies to help reduce the risk of falls. So some great topics this evening. And just as an introduction, falls among older adults, and we consider that greater than 65 years, are very common. They're certainly very costly, and in my opinion, are very preventable. We're going to talk about some ways to prevent those, even on medications. But some interesting stats here: 1 out of every 4 older adults fall each year. So that's a pretty large amount right there. Falls are the leading cause of fatal injuries among older adults. And I can tell you, I've had elderly parents live with me, and I have dealt with both of them having falls, and even falls not even necessarily related to medication. So again, think about that statistic. Falls are the leading cause of fatal injuries among older adults. So this is why we're addressing this evening. In assisted living communities, 15% of residents will suffer from a fall. And any given year, there are 3 million older adults treated in the emergency department, and over 800,000 people hospitalized due to fall-related injuries. So some really large numbers. And that's why we want to talk tonight about how to prevent these and address, and then even looking at medications to be aware of that might increase fall risk, and to get some things we can do to mitigate fall risk. But you can see in the slide right there, the fall death rate in the US has increased 30% from 2007 to 2016. And you can see by the year 2030, it's estimated that if these rates continue as they are, there'll be 7 fall deaths every hour. So it's definitely something that's significant. It's something that we want to address. And that's the reason why we're doing this tonight. So that's just a quick introduction. Gayle, I'll turn the mic over to you for a few minutes and let you cover a few things about negative impacts of falls and some other items.
Sure. Thank you, Curt. So as you can see, falls are very prevalent among older adults. So as a result, there are several associated negative impacts of falls. Physical impacts can include broken bones, fractures, head injuries. Patients often become less active and therefore weaker. These multiple falls also lead to some emotional impacts, such as embarrassment. They feel helpless. Psychologically, they begin to have a fear of falling again. This fear of losing independence kind of sometimes makes them go in the opposite direction, where they don't want to ask for assistance. So they want to keep doing it themselves as long as they can. It's often seen as being non-compliant, but they just have that fear of losing their independence. And just as Curt mentioned earlier about the hospitalizations and all of the fall-related injuries, there's obviously a negative economical impact as well due to cost of physical therapy or assistive devices and the medical care or hospitalizations that are connected to the falls. So what causes falls? There's many risk factors for falls, and just a few that we're going to touch base right here can include weakness, just generalized weakness. That can be due to multiple different scenarios. A vitamin D deficiency, which is sometimes overlooked, a walking or balance difficulty, medications, which we will touch base on here shortly, vision problems, foot pain or inappropriate footwear, environmental hazards. And just know that we will also touch base on some of these later on in the presentation. Now, falls can be classified as preventable or non-preventable. So preventable falls are usually those that are associated with events that could have been caught beforehand, such as environmental hazards. So as you can see the picture below, it kind of gives you a great example of kind of what you may see when you walk in a resident's room. You can see items lying on the floor, rugs that may pose a trip hazard. There could be cords laying around or clothes laying in the floor. Medications are always a preventable fall risk factor. Any unidentified or untreated medical condition, those often lead to complications that can cause falls, such as dizziness, weakness, or confusion, for example. And remember, most falls are actually considered preventable. Now, on the other side of that, we do have non-preventable falls. These can be related to just age-related decline, either acute illnesses or chronic conditions, and past history of falls as well. Now, today we're going to focus on medication management with particular attention to psychotropic medications. Now, there are 4 main categories of psychotropic medications. We have antipsychotics, anxiolytics, sedatives or hypnotics, and then antidepressants. Now, these medications, they're used to treat common medical conditions like bipolar disorder, psychosis, anxiety, depression, and sleep disturbances. Now, each of these categories of medications have properties that can lead to falls. And Curt, I'm going to turn it over to you as you discuss each category of these medications.
Okay, thanks, Gayle. It's a great introduction to the medication piece. And as a pharmacist, we're going to talk about some medications that are definitely associated with fall risk. It doesn't mean these are the only medications that are associated with fall risk, but we do want to address the ones that are most commonly seen, especially in assisted living or even skilled communities. So again, as Gayle said, we're going to talk about psychotropics, and that's kind of an umbrella term for 4 different classes of medications. And antipsychotics is the first medication. So tonight, I don't want to get too deep. I will get just a little below the surface when it comes to pharmacology. I want to be able to teach a few things here, but not too deep. But we have to realize a psychotropic medication is a medication that affects what we call neurotransmitters in our body. And there are several of these. There's dopamine, there's serotonin, there's norepinephrine. And these medications we're going to talk about in the next few minutes are medications that either increase, potentially decrease some of those neurotransmitters in our body to get the effect, the desired effect for each medication. But unfortunately, along with the desired effect comes some undesired side effects. And we'll talk about those in particular here, but a sedation can be one that's common across the psychotropic medication umbrella, if you will. And the first one we'll talk about is antipsychotics. And again, as Gayle said earlier, they are used to treat a variety of indications: schizophrenia, bipolar, Huntington's disease, Tourette syndrome, even certain types of depression. But in many of the cases that we see antipsychotics used in seniors is perhaps with dementia with a little bit of psychosis involved. So, so these medications are given to kind of relax that psychosis, kind of bring somebody back into a little bit of a reality, if you will. And these medications can certainly help with those issues. And you can see the examples that you may be most familiar with. These aren't the only antipsychotics, but these are the most commonly ones that I see as a pharmacist when I look at charts in an assisted living community. You can see quetiapine, which is the brand name you may be familiar with, called Seroquel, risperidone, which is called Risperdal, olanzapine or Zyprexa, and then certainly haloperidol, which is Haldol. Most of these medications have been on the market for at least 20 years. Haloperidol has been in the market since the 1950s. So these medications have been out there for quite some time. So they're not brand new on the market. We know what the side effects are. We know they can be helpful, but at the same time, we know they can also pose a high risk. One of the reasons they pose a high risk is sedation. And the reason they are sedating, and again, I'm not going to get too in depth here, but these medications, they tend to affect the neurochemical dopamine in our bodies. They usually, if there's psychosis, we have a little bit too much dopamine, and what we want to do is decrease that dopamine to get the desired effect. But at the same time, when we decrease dopamine, we sometimes inadvertently also decrease another neurotransmitter called choline. And so when we decrease choline at the same time, we get what's called anticholinergic side effects. Okay, so I'm getting a little bit deep in here, but we're going to come right back out. So bear with me. So when we talk about anticholinergic side effects, one of the biggest anticholinergic side effects is sedation. Okay. There are some other ones, anticholinergic side effects: dry mouth, blurry vision, decrease or constipation, potentially a decrease in urination. But the two things that stick out to me is the sedation in particular, and maybe even blurry vision that can pose a fall risk. So you can see some other things here that are just natural side effects, maybe potentially confusion. We're trying to treat confusion. So it's crazy to see sometimes that drugs can cause some confusion. Sometimes we see that. Lack of coordination, impaired balance, impaired psychomotor function, and syncope. In addition to decreasing dopamine levels, the one disease state that we see decreased dopamine levels in, believe it or not, is Parkinson's disease. So when we decrease dopamine levels, in addition to sedation and some of the other things I talked about, we can also see some of the some Parkinson-like syndrome as well. So you may see some of the rigidity or the trouble walking, okay, that kind of looks like what we call cogwheel walking, if you will. So all of those things combined, again, we're given a drug to help, but sometimes we cause some undesired side effects. And so this is why this category can present an issue, and is probably, in my opinion, one of the higher fall risk medications we're going to talk about, or groups that we're going to talk about today. Okay, so keep that in mind. Again, antipsychotics. Whenever I see these in a chart, when I'm looking through a chart, I always look through. My eyes are drawn to this, that they're kind of red as a red flag, and I want to make sure that the resident is on a dose that supports the indication, and that we are certainly mindful of the potential issues and concerns that we could have. So I'll certainly we would want to monitor residents if they're on an antipsychotic. Okay. So we'll move on from antipsychotics to another class of medication, and these are called anxiolytics. Now, what's the difference between an antipsychotic and an anxiolytic? Again, both of these are under the umbrella of a psychotropic. They affect behavior, but an anxiolytic is different in the fact that we're just merely trying to treat anxiety. And along with anxiety comes a myriad of things. Sometimes when we're anxious, we either sleep too much or we don't sleep at all. Most people, if they're really anxious, have trouble sleeping more than the opposite. Okay. Sometimes anxiety can increase seizure potential. Sometimes it can cause nausea, vomiting, or even GI issues. But again, the bottom line is we're trying to treat an anxiety issue. And as we get older and as we age and as we just naturally have, different disease states that begin to affect us, we can become a little anxious. And especially if you're starting a new medication, that could be anxious, or if there's a change in scenery for someone, that could be a little anxious, cause a little anxiety. And so sometimes it does indicate the need for a medication, either short-term or long-term, or potentially just as needed to treat anxiety. So you can see on the screen the medications that we typically might see to treat anxiety, some that you may be most familiar with. Again, these aren't the only ones, but you may be used to lorazepam, which is the brand name is Ativan, alprazolam, which is Xanax, diazepam, which is Valium, and hydroxyzine, which is called Vistaril. So those are 4 very common medications. There are some others out there, but I just wanted to list the most common medications that you may be most familiar with. And again, when I talk about another neurotransmitter, again, not to get too deep, but these medications inhibit a neurotransmitter, or help to inhibit a neurotransmitter called GABA. Okay, so when we inhibit it, we tend to treat the anxiety, and that's great. But at the same time, like we talked about with the antipsychotics, we also can cause some undesired side effects. And again, one of the undesired side effects when we try to treat something positive, unfortunately, is sedation. So again, talking through sedation, potential dizziness, confusion, and definitely cognitive impairment. I can tell you as a pharmacist, I have seen folks take, especially the Ativan, Xanax, and Valium, And sometimes they may even have a memory problem after taking one of these medications. They may have trouble remembering what happened in that period. Now, that's not everybody across the board, so I'm not here to scare everybody, but that's just something that's possible. So again, when we're talking about fall risk and possible side effects, these are medications that we definitely want to hone in on. So again, my eyes are drawn to these medications. They're higher risk along with the antipsychotics and medications we certainly want to pinpoint when we try to treat anxiety. Okay. So moving on to the next slide. Sedatives and hypnotics. So a minute ago, I talked about when somebody has anxiety, they may have trouble falling asleep. That is certainly common. But just as seniors age, the REM cycle of sleep changes. And seniors tend, as we know, over 65, seniors tend to sleep less. They either have trouble getting to sleep, or potentially they have trouble staying asleep. And so we try to find if if we can't find a non-pharmacologic, in other words, a non-medication way to treat that. Maybe we can talk about some of those in the Q&A session coming up. But if we can't find a way to treat that, we may have to use medication to treat the insomnia. And so you can see some of the examples here that are most common is temazepam, which the brand name is Restoril. Zolpidem, which is Ambien, which is probably the most common one that I see. Zaleplon, which is Sonata. And then ezopaclane, which is Lunesta. Okay. So you may know this by the brand name. You may know this by the generic name. I've seen some of these marketed on TV before, so you may have seen them there. And again, these four medications, I will say the first one, the temazepam, is a very long-acting medication. So it's not one that I recommend we use first, because it does help get someone to sleep. And if they're having trouble staying asleep through the night, that may be helpful because it's a longer-acting medication. But as a pharmacist, I typically like to use something that's shorter acting, like Ambien, if we're going to use something that helps seniors get to sleep and hopefully propel them into a sleep and into a better REM cycle. They stay asleep and they can wake up refreshed the next morning. The Sonata and Lunesta do the same thing. They're fairly short acting as well. So that's my preference of choice, is to start with something short acting. And then if the drug wears off in the middle of the night, then we maybe can look at using temazepam at that point. But that's usually, as a pharmacist, something that I like to look at first. But again, obviously we're trying to get seniors to sleep. So we know these are going to cause sedation. That's what we're actually the desired effect. If we don't get enough sleep, there's problems with that. So we use these medications to get seniors to sleep. So we do have to address the issues of, what if they wake up in the middle of the night, need to use the restroom. I've seen that very common. And so some things that we always like to look at is if you're taking one of these medications and you end up needing to get up in the middle of the night, make sure your feet are squarely on the floor. Make sure that, there may be a bed rail that you hang on to as you stand up very slowly. We recommend standing up very slowly. And certainly we recommend a very predictable and very easy way to get to the restroom or getting to whatever place you need to get to if you're on one of these medications. Okay. So that's sedatives and hypnotics. And moving on to our last category of the psychotropic umbrella, is what I call it, is antidepressants. There are a lot of seniors on antidepressants. Okay. There are a lot of changes that happen as we age, and there is definitely a need to treat depression. There are consequences if we don't treat depression. Okay. So again, we always want to look to non-pharmacological issues first. But at some point when we use an antidepressant, and we have to treat depression because of, I recently, I'll give you a personal example. I had, my father passed away about 6 months ago, and my mom was with him for nearly 60 years. And about 2 months in, just found herself at a place in her life where she had a lot of alone time, and she was not used to that. And she was also used to being a caregiver. Okay. And so when she wasn't a caregiver anymore, there were some things that were not, that, she found a little bit of a void to treat. And so we started her on an antidepressant, and we started her on a very low dose antidepressant. We started low, and we ended up finding out we didn't need to use anything but a very, very low dose. And so that's something we always start with. We start with a low dose of any psychotropic medication, but certainly an antidepressant, we would start with a low dose and titrate very slowly. So antidepressants take about 4 to 6 weeks before we even know where the desired effect is going to take place. And so the good news is, as we watched my mom through the next month, we knew we could keep her on a low dose, and it worked very, very nicely. And for her in particular, we didn't see many side effects, but that's not always the case. And sometimes when we have to titrate after that 4 to 6 week period, if the depression still exists, then we may look at potentially more side effects. And I do see seniors on lots of higher dose antidepressants. And again, there's certainly a need for that. But at the same time, we have to be cognizant that they can increase fall risk, okay? So some examples that you may see most commonly, and some of the ones I see, and this is not an all-exclusive list. You can see sertraline or Zoloft is one I commonly see, Paxil, which is paroxetine, the generic name, Cymbalta, which is duloxetine, and a couple others that are not on this list that I see very, very often is Lexapro and Celexa that you may have seen. They're both generic and very inexpensive. So those are probably the most common ones, and that they're under the SSRI category. And again, I was talking about, kind of chemicals in our body, neurotransmitters. These help to increase serotonin, these drugs I just talked about. And serotonin is a chemical in our body that's a feel-good chemical that typically when we're depressed, we find that there are low levels of serotonin in our body, okay? There are, other categories of antidepressants, tricyclic antidepressants as well. And these are very old medications. They've been around since the 1950s. And these medications help to increase another neurotransmitter in our body called norepinephrine. Norepinephrine is also kind of call it a feel-good chemical in our body that tends to be seen in low levels in depression. And so these medications raise the level of the norepinephrine and help to treat the depression. Okay. So it gives you an idea of all the medications we've talked about, how they're working to increase a certain chemical in our body or a neurotransmitter in our body. But again, these medications are used to treat depression, potentially generalized anxiety disorder, or even peripheral neuropathy. It's kind of a nice side effect if we're not using it for depression. So again, why are they high risk? Well, especially when we start what we call the SSRI, or the selective serotonin reuptake inhibitor, they're very well known to cause dizziness and even sedation in some, especially Paxil, not so much the others, but some can cause insomnia. So we have to dose these, sometimes we have to dose them, according to whether they cause insomnia or not. We don't want to use them at night if they're going to cause insomnia, but I'm honing in more on the fall risk here with the dizziness that can certainly occur in the first 4 to 6 weeks when we start the medication, or if we increase a dose, it can also cause an increase in dizziness. So have to remember that. Anytime we have a dose increase, we can have an increase in dizziness. Okay. Now the tricyclic group that I talked about, that you can see on the slide, they certainly have what we call sedation. When I talked about the anticholinergic side effects earlier on in the presentation, these also have anticholinergic side effects. And again, if you can remember from that slide, the number one side effect of any medication that's anticholinergic is sedation. Again, so anything with sedation or dizziness is going to cause an increase in fall risk. And we want to be hyper vigilant with these medications, again, in 2 areas: when we first start the medication, or if there is a dose increase. Okay. So moving on just a little bit away from the actual categories of medications. And again, feel free to think of some questions that are medication specific. We can address at the end. But when we talk about methods to reduce medication risk, okay, several things. Again, the thing I talked about just a minute ago, The highlight here is in the blue quotation, start low and go slow. We don't ever want to rapidly increase somebody, if it's not working a week later, we don't want to increase the dose. We need to give the drug time to work in all 4 categories that I talked about before we do a dose increase, okay? Start low. Let's see if the minimal dose works. And then 4 to 6 weeks later, let's increase if we have to, okay? Make a good subjective evaluation at that point. Some other things, avoid psychotropic medication. We really want to avoid psychotropics wherever possible. Again, that was the first category of drug I talked about a minute ago. If we have to use them for dementia with behaviors, we can, but we want to avoid those if all possible. And again, look at non-pharmacologic possibilities that Gayle will talk about in just a minute. Again, decrease or discontinue other psychotropic medications if they're on board. If we're adding a new one, we want to consider eliminating the other one that might be on board. That happens all the time where we might increase we add a medication, but we forget to discontinue the other medication. There may be 2 different doctors involved in the process. And so it's always important to keep a solid list of medications. So, and have a pharmacist review those. We want to make sure we discontinue all medications in lieu of a new medication wherever possible, okay? Consider use of medication classes that are lower risk. Always, we want to talk about that. Always try to find the lowest possible dose. Work on sleep hygiene. And this is a non-pharmacologic method that we talked about, as I've talked about, trying to use those first before using medications. Some of those things: reduce daytime napping, keeping residents active through the day, ensure quiet and a dark environment at night. If the room has too much light in it, the REM cycle is going to initiate incorrect and continue to manifest incorrectly, and it's going to interfere with the sleep cycle. Okay. Do not administer stimulating medications on an evening med pass like pseudoephedrine if someone is congested. We want to hold those medications. Do not take those after about 3 p.m. if we can help that. Use for a shorter time as possible. So again, we can use as needed medications. Some of these are not as needed use. Depression is not something we use as needed, but maybe potentially for anxiety, certainly just use those as needed for a short period. And then if the anxiety goes away, maybe we can discontinue those at that point. And always engage your pharmacist to evaluate medication combinations. I know I work for a long-term care pharmacy. Always engage the long-term care pharmacy or whatever pharmacist you feel comfortable with. Take that medication list to the pharmacist. Every 6 months or so, ask the pharmacist, can you take a look at this? Do you see anything concerning? Or if you see behavioral changes at any time, have a pharmacist review that list to see if it's potentially related to a medication. Okay. And then methods to reduce medication risk. So a few other things. Again, making sure that you discard old medication. I can tell you, after taking care of my mom and dad for many years, I've opened their medication closet and I've seen bottles and bottles and bottles. And that may not be something that happens in an assisted living where it's a little more controlled. But if you are caring for somebody in a different setting, make sure you go through and get rid of anything that is old and not being used. And so it's not confusing. I've opened medication bottles where I've seen, my mom accidentally mix medications. So always open the bottle, look in and see if there's something in there that looks different. Take that to the pharmacist, let them look at that. Use of compliance packaging, certainly inside assisted living, that's something that a long-term care pharmacy can provide for you. Education of potential side effects. And we're kind of doing some things we're doing right now, working with your community to have pharmacists speak to the community about potential side effects and asking about those. Pharmacists should always be available to talk to you about that, even if it's through a nurse or through the pharmacist communicating through the nurse. And then again, one of my favorite things is make sure that you have a complete list of all medications for MD appointments. every time you go to the doctor, no matter whether it's a specialist or primary care, you know, go get that med list printed off from the either assisted living, or if you're keeping track of that, make sure it's complete. So you've got that available to go to the doctor each time you go to the doctor, and make sure the doctor sees that. Okay. And Gayle, I think I'm going to transfer this to you and let you talk about methods to medicate, a few more methods to reduce medication risk, and then moving into some other slides that talk about mitigating maybe some non-pharmacological ways to mitigate fall risk.
Good deal. Thank you, Curt. First, we'll talk about some methods to some additional methods to reduce medication risk. If you are a nurse in the facility, or patient, or a caregiver, if you have any questions about dosages, frequencies, or the appropriateness of any medication that you have been ordered, please always feel free to verify that with the doctor or the pharmacy to make sure that you're being given the right medication for the right reason at the right dose. Anytime there's a new medication, or if you have any medication changes in the last 5 to 7 days, or with any fall, those patients need to be monitored more closely. If you do have a fall, kind of go back and look at what meds have I taken in the last 1 to 2 hours. Could that have contributed to that fall? Is that something that I need to adjust? And then always ask your pharmacy if maybe you have a concern about the medications that you're taking, to make sure that there's no interaction, or maybe the timing of your medications that could be related to the fall. Always have your pharmacist review those as well. Additionally, we've already touched base on the psychoactive medications, and as Curt explained in much detail how those can affect falls. Some additional medications that can also cause falls are medications related to Parkinson's disease, heart problems, if you have any blood pressure issues, if you're on medications for your urinary system of any kind, pain, seizures, sleep, anxiety, nerves, we've talked about those. Any medications for epilepsy, any painkillers. I think Curt already touched base on some antihistamines. Anything like that, those can also cause falls. So make sure you know those risks that are associated with those medications. And remember, when a resident is on one of these, they're already at an increase for a fall. So when they're on more than one, that makes them at even a higher risk of falls. So now that we know the medication side effects that can happen with these psychoactive medications, we want to make sure and start with some non-pharmacological interventions, as Curt said, some non-medication related interventions for those behaviors or symptoms that would normally warrant the use of those medications. If you start having some behaviors, or your patient starts having some behaviors that are a little unusual for them, make sure and assess for any acute illness, like any sort of infection, dehydration, maybe your urinary tract infection. Those can all lead to increased confusion and behaviors among senior adults. Assess for pain. Maybe they're not really able to express to you that they are in pain. So look at those nonverbal cues and see if maybe pain is an issue. Hunger. Maybe they would like some snacks, or maybe an additional shake or supplement if it's not close to mealtime. Evaluate their vision and hearing. If you can't see well, or you can't hear well, a lot of times it's a little disorienting, and all the additional environmental noise and everything going around just can kind of increase the confusion and agitation. So assess for that as well. Physical exercise. If your patients are used to getting up and moving around and going to work and cleaning the house, not having that activity can cause behaviors. They're used to being up and doing things. So encouraging participation in activities, physical exercise, engaging in tasks that makes them feel needed, such as folding towels or papers, helping them sort items. Maybe what did they used to do as their career? Maybe you could institute some sort of activity related to that. play their favorite music or a favorite television show, or show them pictures of their family, or have a slideshow of pictures going, something that might be familiar and calming to them. And of course, relaxation strategies as well. A shower, a warm shower, a bath, a massage, or maybe aromatherapy might be some additional options. All right. Next, we'll talk about a fall reduction program. So we've talked about how to implement, some side effects of the psychoactive medications and some non-med interventions to put into place to prevent us from necessarily having to use those medications. But on top of that, we always need to have a really good fall prevention program or a fall prevention approach in place. And one of the main topics of that is your education. You really need to make sure that your staff is well versed on what to look for as far as fall risk goes. Don't forget that you do need to educate your resident and your family also on general fall risk factors. Also, any new meds, make sure everyone is aware that the particular patient or that your loved one has been started on a new medication, and always ask the pharmacy or the doctor, like, hey, what do I need to look for in this medication? What are some of the side effects that I need to look for? Now, if a fall does occur, it's so important that you investigate at the time of that fall, and a thorough investigation is needed. You need to assess the resident and the surroundings. For example, if you can pick up on some cues at that time, you might really figure out exactly what happened, what was the root cause of that fall. So for example, was there water in the floor? Did they complain of dizziness? Were there any incontinence issues? Look at their footwear. Did they have shoes on? Do they have socks on only? What shape was their footwear in if they did have it on? Was their wheelchair locked? Were they wearing their glasses? What's the lighting in the room? Those are all things that you can look at the time of the fall that will help you put the appropriate intervention in place. If you don't really do that really good, thorough investigation, then you tend to kind of put an intervention in place that's just like putting a Band-Aid on it. It doesn't really solve the problem, and future falls will occur if you don't investigate thoroughly. When you're doing the fall investigations, it's always important. Another piece to the puzzle is a team approach. Always ask the frontline staff. They are those that are with the patient most of the time, or any caregivers that are in there with the patient taking care of them day in and day out. They can often give you some really good information on what happened maybe at the time of the fall, before the fall, or sometimes it's just a matter of what the normal routine for that patient is. So always look for your frontline staff, maintenance department, dietary, activities, therapy department, and don't forget the resident and family. When you're investigating these falls, talk to the resident, ask them what was going on at the time of the fall. And it's a team approach. It takes everyone's ideas to really figure out sometimes what's going on with the patient and how we can prevent these falls. If you use that really good team approach, you're going to be able to implement individualized interventions that are effective and can help prevent future falls. Now, the next few slides, we're going to review some very basic fall risk factors and interventions. And they do seem simple and obvious, but these are often overlooked on a daily basis, and overlooking these can lead to preventable falls. So one of the first ones we're going to talk about is poor fitting clothing or shoes. And I kind of touched base on that earlier. You need to make sure that they have really good non-slip soles and in good shape. I often see, those favorite pair of house shoes that they just don't want to give up, or, pair of tennis shoes that they're able to slip on easily. The shoestrings are torn, tattered, dragging the ground. Try to figure out what pair of shoes they might be comfortable in, but some that are really in good shape that will prevent falls. Encourage them not to wear socks without shoes, especially, as Curt was talking about earlier, when they're getting up in the night. especially if they've taken any sort of medication that could cause dizziness. It's very important that they understand they need to slip on those non-skid house shoes, for example, and make sure and put those on before they get up. Always look at the clothes. A lot of times the robes might dangle to the floor, or they'll have long pants on that they can trip over. So look for those sort of things. And if we, like I said, if we look at those ahead of time, we can prevent falls from happening. If you notice that there's a decreased mobility or weakness, that's a time that you really need to encourage some therapy when indicated, or an exercise program. These are going to strengthen those thigh muscles and improve your balance. If you're a caregiver in the home and you're thinking, I have no idea what exercise program I need to put into place, you can use YouTube. They have some really good just senior exercise programs they can sit in the chair and do. They can move their feet a certain way. Those are really good things that you could institute for your loved one as well. And, if you make those, sorry, Curt, if you can make those exercise programs kind of a social event, then a lot of times they'll increase the participation, make it fun, okay? Some additional fall reduction measures include dealing with incontinence issues. Now, sometimes this is uncomfortable for some of the patients to discuss, and they often don't really want to talk to you about it or let you know that this has become an issue. But if it has and it's something new, then obviously you want to discuss with your provider to make sure that there's not something acute going on, like maybe a urinary tract infection, or maybe they need to be treated for some other, situations that are causing some incontinence or some dribbling. But if that is the situation, talk with your resident, and do they need a commode or a urinal near the bed so that it makes it a little bit easier for them, especially in the night after they've taken their medication. Sometimes they might need some pads, briefs, or waterproof bed sheets. And I know we've touched base on the environmental a little bit along the way, but if your loved one has any pets, that's something to take into consideration too, to make sure that they're not a trip hazard. Carpets, it's a great example. You walk in a lot of times and you'll see little rugs placed everywhere throughout the apartment, and a lot of times they're not in the best shape, and they kind of have peeled up on the corners. So always look for that. Make sure that the furniture is in an appropriate place as well. If your loved one or your patient is in a wheelchair, for example, or uses a walker, make sure that they don't have to dodge tables or chairs in order to get around. Check for lighting. Make sure they have adequate lighting, and lighting that they can turn on easily as well. If they can't get to the lamp, or they can't get to the switch, that is going to make a little bit less likely that they're going to turn them on. And if it's dark in the night, then they're not going to, then they could possibly fall. So make sure you have adequate lighting available and easily accessible for them in their apartment. Look for any sort of cords lying around, extension cords, or, if they like a fan and they have fan cords or whatever, make sure that those are out of the way and tucked away so that they don't trip on those. And also, if you have a new resident in your community, it's new surroundings, things are unfamiliar to them. It's a little scary too. So they probably have a little anxiety about moving in. So, do a really good thorough assessment, make sure you orient them to their surroundings, and that will also help prevent falls as well. Now, I think we touched base on this a little bit about medications that are treating certain conditions that can also lead to falls. So you have certain medical conditions in itself that just can, cause falls. They can cause those falls. We talked earlier as far as non-preventable falls, dementia, Parkinson's disease, osteoporosis, diabetes, seizures, hypertension, which is high blood pressure, or hypotension, which is low blood pressure. Now, these all may require proper interventions based off the symptoms. Each patient is a little different. They may need individualized interventions based off those symptoms that will help minimize the complications. And a good example I always give is Parkinson's disease, for example. Making sure that you give those medications timely at the same time every day. A lot of times they'll take it at a certain time before they get up and start their normal activities of daily living, to help get them through those activities without many complications. Impaired vision. This is another biggie for me. I feel like if you don't have that regular eye exam and you're not using those glasses, think of how disorienting that can be to try to maneuver around in your apartment, whether you realize where, you're used to that environment or not. It can still be very difficult, especially in the night, to be able to navigate through that. So make sure that those corrective lenses that they are using are in good repair, that they have an up-to-date prescription for those, and that they're being used. And if you walk in and your patient's never using those glasses, then find out why. Maybe they're too tight on the ears, or they're too tight on the nose, or maybe they can't see out of them at all anyway. So that could be a time that you need to get them back to the eye doctor in order to get a new pair of glasses. Okay. So in review, a good fall reduction program includes assessing the resident and the environment. Like we said, doing a really good thorough assessment before fall. It doesn't need to be just after a fall, but you need to find these interventions beforehand, and make sure that you put them in place before a fall occurs. But if a fall does occur, again, investigate very thoroughly. Don't forget to educate. It's so important to educate your staff, educate your family, your resident. Let them know what they need to look for and how they can prevent falls. Always use a team approach. Using a team approach to investigate and implement appropriate interventions, appropriate individualized interventions. And remember, don't overlook those simple yet effective solutions, and always reassess when needed, like after a fall, after an acute condition, when they come back from the hospital with any changes. Make sure you always reassess those.
Okay, thanks, Gayle. That was fantastic. And actually, it was great for me to hear as someone who's a caregiver as well. So some fantastic tips on non-pharmacologic, which can certainly go a long way. I did want to provide a reference page. We can certainly provide this if you email us. We'll provide another contact here for you in just a minute as well. But I did want to provide just a reference page where we found some of the material that we presented tonight, if you are interested in that as well. So with that being said, I'm going to go ahead and stop. I'm going to take the presentation off the screen, and that will conclude the presentation. And now what I'd like to do is do a little Q&A session in the remainder of the time that we've got tonight. So what we'll do is, if we've got several questions, so that's fantastic. So let's go ahead and start with the first question here. Can you recommend any particular foods or diet that may help with mood or happiness as opposed to an antidepressant? So that is a fantastic question. Maybe Gayle and I can kind of go back and forth. I would certainly recommend, I think this just kind of goes in general, in my opinion. I'm not a dietitian, but as a pharmacist, I can tell you just a good, healthy, organic diet. You don't have to go buy completely ridiculous, expensive organic things, but just a good, healthy, balanced diet that includes protein, that includes vegetables. I know that's difficult sometimes. I know in my dad's last few months, there was only a few things he was interested in eating, but to the best of our ability, I think a really healthy, balanced diet is very important. And again, one of the things we try to hold off the meds as long as we can. That may not be possible. I would also recommend, not using a lot of just an excess salt. I think normal salt is okay, but excess salt tends to cause swelling, which could potentially increase edema in the lower legs and increase weight in pounds. So we don't want to do that and cause potential fall risk. That's probably my words of wisdom on the diet. Gayle, anything you want to add as far as diet's concerned?
Hey, Curt, that's exactly what I was going to say, is just eating a very well-balanced diet. That's exactly what I was gonna recommend as well.
Okay, perfect. So that's a fantastic question. Thank you so much for that. Great question. We have another question as well. Any advice on how to best manage all of your medications from multiple doctors? Wow. Okay, that is a fantastic question, and something that I'm sure Gayle has some things to say about this as well, but I can just tell you from a personal point of view, because my parents, my mom still lives with my wife and I and our family. And my dad was on 13 medications before he passed away, and my mom was on 8. And so I can tell, and I'm a pharmacist, and I can just tell you how difficult, even as a pharmacist, and this is my job, this is what I do working with seniors. I can tell you how I so empathize with that question, because it was very difficult for my mom to keep track of both her and my dad's medications. But I would just say, it takes a lot of vigilance, and just, there's nothing wrong. There are times where I've had to call her cardiologist to make sure that we are on the right dose, and that, this is the right medication. Did you really want her to be on this, or did you want him to be on this? My dad saw a neurologist, and sometimes I would go home, here I'm doing my job all day, working with seniors in our communities and our assisted living communities, and I would go home, and all of a sudden my mom would say, "Hey, we're having a medication sent to the pharmacy to get filled, and from the neurologist for Dad." And I would go, "Do you know what that medication is?" And she would say, "No, I know it's for this." So it is hard to take, but it really put a lot on me to take some responsibility. And sometimes I just have to call the neurologist and go, "Can you give me a little bit of a recap on, would you mind calling me back?" Because it's usually a call back. But with them, and they had great doctors, and the doctors were always willing to call me back and have a brief discussion with me. I'll say this too. I tried to attend the doctor sessions wherever I could. I tried to take them to the doctor so I could be in the room with them whenever I could, so I could hear. That's not always possible, because we all have jobs, we have other things that we have to manage and families to manage. So I totally get that. It's a lot to juggle, but if you can be with your loved one when they're with the doctor, that's certainly helpful too. But manage, keeping track of that list. If they're in a community like Morning Pointe, the community can certainly help you assist with that, and give you a comprehensive list as well. So Gayle, anything you want to add to that?
Yeah, I was just going to say, making sure, that you keep that all-inclusive list of those medications with you at all times. Make sure you add to that, and take that to the doctor with you. Keep it on your refrigerator, keep it in your purse, and always try to use one pharmacy. That way, that pharmacist is able to look at the medications, be able to tell you what may be interacting with one another. They can clarify with the doctor as to why you're taking those medications, and they can even print out a list for you. So definitely try to use one pharmacy and keep that list active.
Yeah, and one more thing I'll add to that question that I just thought about is, make sure that you include over-the-counter medications as part of that medication list. Because just because you can walk into a pharmacy and buy Benadryl is very sedating. We didn't talk about that in the presentation, but there are a lot of sleep aids that you can just walk in and buy over the counter that can be very detrimental to when we're talking about falls. So be very cognizant that just because it's over the counter and it's an herb or a sleep aid or vitamins, even vitamins aren't benign either. They do interact with other medications. Make sure that you include over-the-counter medications. So I always wanted to make sure that I would go in and look in some drawers inside my parents' nightstand and make sure they hadn't bought anything if they made a trip to a Walgreens or wherever, and make sure there's nothing over there as well. So just another little piece of the puzzle to add. Okay. Looks like we have one more question that is a really, really good question, a very personal question. My mom is on at least one of those medications in each category that we discussed a minute ago. and already's had 3 significant falls.
Mm.
And she must take the meds. Any suggestions? Gail, I'll let you, why don't you start first on that, and then I can kind of wrap up.
Sure, sure. So this is a hard situation because sometimes this is just the way it is, you know, for one reason or another, they need those particular medications. But one thing I always recommend is to make sure that they are on the lowest dose possible. You know, sometimes when a condition begins, maybe they did need a certain dose, or maybe they did need that medication. So always have a review, you know, every few months, you know, have your pharmacist or your doctor have them review that to make sure that they are on the lowest dose. You know, decreasing, maybe if you want to take one of those medications, say antipsychotic, for example, you know, and start doing a very small gradual dose reduction, then maybe eventually you can possibly just completely come off of that one particular med. It is a slow process, but I see a lot of times, and surprisingly to everybody, how the patient can actually come off some of those medications, especially after that acute condition has been resolved. And as they come off those medications, you know, look at those non-pharmacological interventions that we talked about earlier. You know, see if you can put any of those in place for any sort of behaviors that may be come into surface once you start reducing those medications. But try to put those in place versus putting them right back on the medication.
Yeah, those are great points, Gail. I can personally affiliate with you. My dad had insomnia, and had to take one of the sleeping medications that we talked about earlier. It was going to be detrimental if he didn't sleep at night. That was going to cause a problem. Might even fall risk if he didn't sleep. So we had to give him something to sleep, but he did have a fall while he was on one of those medications. And just to Gail's point, after the fall, he broke a hip after taking one of those medications. Did find through rehab about 3 years ago, but we did, when he came out of the hospital, we brought that sleep medication, we cut it in half. And we ended up finding out that half the dose worked just as well as the higher dose did before. So that's a great point, Gail. Always look for dose reductions where we can. You know, I would even encourage, sometimes we have pharmacy consultants that come into, if they're in the community, if they're at Morning Pointe, a pharmacist consultant is always helpful to come through and look at a chart, or even just, again, just simply asking a pharmacist if you know a pharmacist, or the pharmacist, if it's a retail pharmacist, taking the list of medication. I always, recommend if you see something change, if they look unstable on their feet all of a sudden, but nothing has changed on their med list, we may be looking at needing to do a dose reduction at that point. Take that list to the pharmacist, let the pharmacist review it, and they have the knowledge base, to be able to help you on those dose reductions at that point. So I hope that was helpful. That question really, really hits home to me personally. So thank you for asking that. It's fantastic. I did have another question come over, and so we'll take this one last question, and then we'll wrap up right after that. Are there any common over-the-counter medications that have an unusually high fall risk? And I think I can probably start on that, Gail, and I'll maybe let you finish up with anything I missed. But I think the number one medication that I see a high fall risk with is sleep aids. There are a lot of them that are over the counter. I mentioned Benadryl, and keep in mind, sometimes just because you see Benadryl, the generic name is diphenhydramine. You may see that as, that Walmart has their brand that has a different name. Walgreens has their brand. And so they all come in different names, but basically they're all Benadryl, which is diphenhydramine. So it's one thing I recommend to do if you're going to purchase something over the counter, especially a sleep aid. Turn the medication over and look at the active ingredients on the back of the box. They're required to have active ingredients on the back of the box. Take that to the pharmacist before you purchase it for someone and ask them, does this active ingredient have a problem? Antihistamines, another category of medications. In addition to using Benadryl as a sleep aid, it's also an antihistamine. When we have a stuffy nose or a runny nose or hay fever during this time of year, it's those common symptoms that occur in the spring or the fall. So look for medications, like Benadryl, but also there are other, Zyrtec is over the counter. Again, it comes in many different forms. The generic name is cetirizine. So turn that box over and see if you see cetirizine, no matter if it says Zyrtec on the front or an off-brand that, again, the pharmacy sells. Allegra is another common allergy medication as well. So those are kind of the ones that I hone in on. Gayle, anything out there that you think over the counter that you feel kind of suspect?
I was definitely going to suggest Benadryl. A lot of times I see, patients come in that have taken Benadryl for years for sleep. So we always try to encourage them to try some other options, like some of the non-pharmacological interventions we talked about, or maybe some different medications versus that Benadryl.
Yeah. And to look for herbal products as well. I know seniors do buy herbal products. They're available over the counter. There are several out there that are sedating. St. John's wort, ginseng, ginkgo are some 3 of the more common ones that I see, and they do carry a sedation risk too. So, but again, if it's something you're going to, buy over the counter and you're with them, take that to the pharmacist and if there's any fall risk. I think it's a great thing to do. Okay. Fantastic questions. Thank you so much for your participation tonight. Again, it's a topic that's kind of near and dear to our hearts, to Gayle and my heart. So we thank you so much on behalf of Morning Pointe for letting us be with you tonight. And I think we're going to put up a slide that has our contact information on it. I think that's loading right now, so you can kind of see if you have any questions about tonight's presentation. If you can think of a question that you just comes to you after the presentation, we've got 2 ways to take a look at that. You can see our website and phone number. We have a toll-free phone number listed right there. You're more than welcome to call, and we have pharmacists that staff the pharmacy. You're more than welcome to call me and provide that question on your phone number, and I'll be glad to call you back, or Gayle as well. You can also see our website, guardianmidsouth.com. Feel free to submit a question, and that comes straight to me, and I can have Gayle and I answer that question. Or you can go to Morning Pointe Foundation, the phone number there, submit your question via the toll-free number that you see there listed on the slide, or the email or the website listed there as well. They can get those questions to us. We are more than happy to follow up with you if you can think of anything as well. So with that being said, again, my name is Curt Bicknell. Again, I'm a pharmacist, president of Guardian Pharmacy Mid-South. It's been an absolute pleasure to be with you tonight on Caregiver Café. And Gayle, I'll let you say your goodbyes. And then again, thank you so much.
Thank you all for joining us. We really enjoyed sharing this information with you all, and thank you to Morning Pointe for allowing us to be on. And I hope you were able to take away at least one valuable piece of information that can help you take care of your loved one, or help you in your community. Hope you all have a great evening. Thank you.
Thank you so much. We appreciate you being part of the Caregiver Café tonight. Good evening.
Thank you for joining us for another Morning Pointe Foundation Caregiver Café. You can find this episode and all of our webinars at morningpointe.com/caregivercafe. Thank you.